morning and Assalamu alaikum. Distinguished chairpersons and learned audience. As this is a tutorial session, we have seen the patient is prepared, bypass established, now the double valve replacement. Double valve is required for the treatment of some effect of rheumatic heart disease or degenerative valve disease, infective endocarditis sort of things. And first double valve replacement was done in 1961 in Pennsylvania. As you heard the pre-operative, that includes mainly the assessment of the patient, of the condition, the function of the heart. We have to take care of whether there is failure. If there is failure to be controlled first, and also should have looked for the lung function and thyroid function, all these things, and of course the renal function also. And if there is any failure to be corrected fast as much as possible, and lung function to be improved, and the decision to be made with if necessary, with the pulmonologist. And for the valve replacement, we need to select our valves through the mechanical or bioprosthesis. Bioprosthetic valve is usually used above 65 years and above, and below that age it is mechanical valve, but this is the age between 55 and 65 is considered as a gray zone. It can both metallic and can be bioprosthetic, can be selected. Usually below 75 it is the metallic valve. And after putting the patient into sleep, lines are given, and an important thing, a TE probe to be introduced to see the valve and function after surgery, and of course effective dearring. After median sternotomy, we do as you said, the patient is put on pump. And after putting the pump before cross clamping, this cardiopulmonary bypass strategy, we use Austrial CP, selective St. Thomas cold blood cardioplegia, 4 degrees centigrade. Retrograde CT maintenance through retrograde, and repeated every 20 minutes. And in case of AS, usually we apply double dose of the CP. The systemic cooling to 28 degrees centigrade, and for surface cooling, we use cold water, ice cold water, or at times ice slush. And the air vent is pushed through the right upper pulmonary vein. After the applying of the cross clamp, aortotomy done usually it is 12 to 15 millimeter above the RCO origin, and it's a hockey stick incision. The lower end is going towards the middle of the non-coronary sinus. And it's important to keep enough aortic tissue for aortotomy closure. CP given by selective cannula. Subsequently, the disease native valve is excised. In book, we have written, in case of calcification, to use the rongers, but we found if it is a tough, long artery forceps, we can crash the valve, calcification along the annulus, and excise it, and after crashing the annular calcification usually leaves a rim of tissue for holding the stitches. And then the sizing is done. For sizing, to avoid patient prosthesis mismatch, there is an app that gives us the idea about which valve, what size to be used for that patient. That valve should be selected, and sizing is done with the sizer. Usually when the sizer fits snugly with the annulus, one size lesser valve is used, or if the sizer should fit loosely, and that size of valve to be used. And after excision of the aortic valve, then we go for mitral through a biatrial transseptal approach. And with this approach, usually the mitral valve is exposed very close to the surface and easily be visualized. Excision should begin from the middle of the anterior leaflet by using 11 stab knife, taking care not to injure the LV. And the valve is anterior leaflet is excised first anti-clockwise towards the anterolateral commissure, and then clockwise to the posteromedial commissure. After this valve is excised, we try to preserve the posterior mitral leaflet for a better LV contraction. The LV annular size is again decided by the sizing as previously done. The valve is replaced with interrupter suture. Root of LA and IA is closed. Interrupter plus, after closing of the LA and interrupter septum, then we go for the atrial valve replacement. Normal valve is after, as was the size decided by the sizer, we put that valve with interrupter sutures. At times we put the placentals below the annulus, below the excess annulus part. After closing the aorta, close the aorta, usually double layer. First layer is horizontal mattress, and then the second layer is over and over, continuous suture. After that, we go for rewarming, and at that period, retrograde CP cannula is removed. And antegrade CP cannula is placed for deaeration and decompression. Cross clamp released, and allow the heart to beat, and nursing the heart at least 1/3 of the total cross clamp time. And during this period, aortomy is closed. Postoperative issues include the ventilation strategies. After double valve, usually we pass at least 8 hours of ventilation minimum or overnight ventilation to allow the edema of the heart to subside and regain the function. And at times they require pacing, and that pacing, because of pulling and stretching, there may be arrhythmia. So patient may need pacing, and we have to wait for the sinus rhythm to come back if it doesn't come. We have to be judicious about using the inotrope vascular sutures. And next comes the question of anticoagulation and so on. The valve is there. After extubation, next day, we start with the warring, 5 mg daily. The INR strategy, our strategy is to keep the INR between 1.5 to 2, and with warring, at times we aspirin 100 mg also. The checkup usually see after 7 days before discharge or during discharge, we see the INR, check echo, and the fluoroscopy to see the valve motion. And routine follow-ups are performed at the 1 month, 3 month, 6 month interval, and then yearly. So this is how this is the basics of the how to DVR to be done. Thank you.